Welcome. Have you ever experienced a sudden, intense spinning sensation triggered by a simple head movement? It could be benign paroxysmal positional vertigo or BPV. In this video, we'll explore what BPPV is, what causes it, and how it's treated. Let's dive in. BPPV at its core is a mechanical problem within the inner ear. Specifically, it's often caused by dislodged calcium carbonate crystals, called otoconia, that normally reside within the utricle and saccule. These crystals somehow get misplaced into the semicircular canals, usually the posterior canal. While the exact reason for this dislodgement is often unknown, head trauma, inner ear infections, or even just the aging process can sometimes be contributing factors. To understand BPPV, picture the inner ear as having fluid-filled canals. These semicircular canals are responsible for detecting head movement and sending signals to the brain about our orientation in space. When the otoconia are in the correct place, they don't interfere with this process. However, when these crystals dislodged and float into a semicircular canal, particularly the posterior canal, they disrupt the normal fluid movement. Head movements then cause these crystals to tumble around, creating an exaggerated and false sense of motion, leading to the spinning sensation we know as vertigo. BPPV is a relatively common condition, especially as we age. It's estimated to affect up to 3% of the population at some point in their lives. While it can occur at any age, it's most frequently diagnosed in individuals over the age of 60. Women are also slightly more likely to experience BPPV than men. The most prominent symptom of BPPV is vertigo, that overwhelming feeling of spinning or the world moving around you. This vertigo is typically triggered by specific head movements, such as turning over in bed, looking up, or bending down. The episodes are usually brief, lasting from a few seconds to a minute. Other possible symptoms include nausea, vomiting, dizziness, lightheadedness, and a feeling of unsteadiness or imbalance. While disconcerting, BPPV usually doesn't cause any hearing loss or neurological problems. Diagnosing BPPV typically involves a thorough medical history and a physical examination. The Dix-Hallpike maneuver is a key diagnostic test. During this test, the healthcare provider will quickly move you from a sitting position to a lying position with your head turned to one side. If BPV is present, this maneuver will often provoke the characteristic vertigo and nystagmus, which are involuntary rhythmic eye movements. The direction and type of nystagmus can help determine which semicircular canal is affected. BPPV is primarily classified based on which semicircular canal is affected. The posterior canal is the most common site, accounting for about 89% of cases. Less frequently, the superior or horizontal canals may be involved. Knowing which canal is affected is crucial for selecting the most effective treatment maneuvers. Another classification considers whether the otoconia are free, floating at canalithesis, or attached to the cupula s cupulolithesis, although this distinction isn't always clinically relevant. Fortunately, BPPV is often effectively treated with specific head maneuvers known as particle repositioning procedures. The Epley maneuver is the most common and effective treatment for posterior canal BPPV. It involves a series of head and body movements designed to guide the dislodged otoconia out of the affected semicircular canal and back into the utricle, where they belong. Other maneuvers, such as the Semont maneuver or the Lempert roll, may be used for different canal involvement. Medication can help manage the symptoms of nausea and dizziness during an episode, but they don't address the underlying mechanical problem. In rare cases, surgery might be considered if the repositioning maneuvers are ineffective. While preventing BPPV entirely may not always be possible, especially as we age, there are some steps you can take to reduce your risk. If you've experienced BPPV before, avoid sleeping on the affected side. Gradual head movements and avoiding sudden changes in head position can also be helpful. Treating any underlying inner ear conditions promptly may also contribute to prevention. The prognosis for BPV is generally excellent. Most people experience significant improvement or complete resolution of their symptoms with particle repositioning maneuvers. Recurrence is possible, but repeat treatments are usually effective. Recent research continues to refine diagnostic techniques and explore the underlying mechanisms that lead to otoconia displacement. Some studies are investigating the role of vitamin D deficiency in BPPV and its potential link to recurrence. With proper diagnosis and treatment, BPPV can be effectively managed, allowing individuals to return to their normal activities. If you suspect you have BPPV, consult with a healthcare professional for accurate diagnosis and personalized treatment.